Let's see, where are we? Here we are.
Here we are.
Okay, we're meeting with Dr. Newberger for 15 minutes, so we're going to get the most of it. So you talk to me.
Okay,
Yeah.
so first of all, her case is unique, so it's very hard to draw any conclusions or inferences from other cases.
Right.
I think that the combination of an Elaine mutation with the colon, could certainly have a synergistic effect to cause a more severe neutropenia. On the other hand, Cohen syndrome can be quite variable
Right.
in and of itself.
Right.
So it's very hard to tell whether the Elaine mutation is actually contributory or not. One of the problems, and I think this is true, but correct me if I'm wrong, is that Elaine mutation has not been reported elsewhere.
That's what I think it said.
Right.
Yeah.
And so the question is it a neutropenia causing mutation, or is it a polymorphism, just a variation in the DNA sequence? It's certainly not a common one. That was
Right.
ruled out as
Right.
well.
Right.
And there's no good test for what's a significant mutation and what's not.
Right.
Dr. Dale was showing that structural diagram, and it might be worth sending him the mutation to put into their computer program.
Well, they have a slide.
Uh-huh.
Well, they have a slide of Michaela's bone marrow.
Uh-huh.
When they did her last bone marrow in January, Adriana had me send them a slide of the bone marrow. So would all the information be there?
No.
Okay.
No. So you have to send him the mutation, the specific.
Well, is it in here?
It's in there.
He
yeah.
has this.
Okay, so ask him to put that into his model,
Okay.
into his computer model.
Okay.
But the trouble is there are multiple computer models,
Okay.
and they give different predictions because protein structure is so complex
Okay.
that the computers can model it. So the only way to know for sure is to create a cell line or an animal model, and that's a tremendous amount of time and expense.
Oh, I'm sure, yeah.
So I think what's said in the paper is that yes, it could contribute, and the Cohen syndrome could be the reason why. I believe it's her father who has the same.
He has both genes, yes, as well.
Right.
Yeah.
But doesn't have neutropenia.
Doesn't, well, I think he's shown signs in the past. Me knowing him on a day-to-day basis, he's had some severe infections.
Uh-huh.
He's never been treated.
Has he ever had a blood count during those times?
Well, I don't know. We're not married anymore. I don't think so. I don't think that's an avenue that he ever goes down.
Yeah. So he may or may not.
Right.
But certainly not
I think
severe.
when he was tested for all the things throughout the years, every time he was tested, he didn't show signs of neutropenia.
Yeah.
He wasn't neutropenic.
Okay, so he doesn't have severe
No,
chronic.
no.
But in fact, what the conjecture there is certainly plausible.
Right.
Of the combination. But the alternative that it's an incidental finding, that's certainly quite a coincidence
Right.
to be in the Elaine gene,
Right.
could also be true.
Right.
And it doesn't tell you much about treatment.
Well, now they want us to follow her. For so long, Cohen syndrome. No, bone marrow not needed.
Yeah.
Not needed. No. And they've always known that she had both genes.
Right.
Her hematologist. But as of last year, and now we're getting ready to age out of her hematology group because she's going to be 21. Now it's like, we need to bone marrow. We need to bone marrow. And so they really want us to watch carefully for the MDS, which kind of turned my world upside down.
Yeah.
But for some reason, at this point, they want to do that.
Yeah.
So that's kind of the road that we're.
And then what are they going to do? Are they going to do it
And
yearly?
it would be, we're going to do it yearly.
Uh-huh.
And if they do find that it does come up, then obviously the next step would be bone marrow.
Yeah.
So
Transplant. Yeah.
so
It's a tough one because.
because it's not known.
Right.
And like what Dr. Boxer told me at our conference, you got the roll of the dice, you got the bad luck, and Dr. Wong, who's our Cohen syndrome specialist, but we're paving the way for other families. Now it's known that someone with Cohen syndrome also carried the ELA2 gene.
Yeah.
And so if they start seeing Cohen syndrome kids that present with severe neutropenia, that they can go look for that other gene and see if she's not the only one. Maybe she's not the only one.
Yeah.
So far, we've had a few families test, and they've not come up positive for the ELA2.
Yeah. And has she ever had a bone marrow?
Oh yeah, she's had 2.
And what do they look like?
They were fine. In January was her last one, and it was fine.
I'm sorry, was that in here?
No, this is the this was before.
This is-
yeah, this was like
So when you say fine, it showed full
everything was
maturation?
fine. Yep, everything was fine.
Okay, yeah, so to me, that would be an indication she doesn't need more.
And they want to do it every
Because
year.
the classic severe congenital neutropenia, was that on Neupogen or off Neupogen?
Oh, she's been on for since 2010. So
Okay.
on.
Okay, so that, what I would do, and again, this,
And that's what I want to know.
there's no truth here.
Right, I understand that.
I would stop the Neupogen for a month
We
and do a
did.
bone marrow
Oh, okay,
and see what the bone marrow looks like off of Neupogen.
okay,
If it shows a classic severe congenital neutropenia defect with promyelocyte at maturation arrest, that is more of an indication to monitor the bone marrow.
okay.
If the bone marrow shows something much milder,
Right.
then I think you have to say she doesn't have that biological
Possibility.
predisposition.
Right, okay.
Because in fact, what the data that Dr. Dale presented today show is that the myelodysplasia leukemia is a much higher risk in patients with certain mutations
Right.
in ELAINE,
Right.
not all of them.
Right,
And those are correlated with the most severe bone marrow defects.
okay.
And they're correlated with the need for the highest doses of Neupogen.
Okay. Well, as soon as she goes off Neupogen, we tried to go, because she's every day, 0.25 ml, so 75 micrograms
Yes.
every day, which is a low dose.
Yeah, which is also
And she
good
does
prognostic.
fine. Yeah, she does fine, which I
Yeah.
got today is good.
Yeah.
And she stays at about like 1200
Mhm.
with that. We tried going I think in May, we tried going to 3 times a week, 25 mLs.
Mhm.
And we tested, because she tested once a month, we tested 2 weeks and she went down to 500. And then we tested 2 weeks later and she was like 200.
Yeah.
So it was obvious
Yeah.
that without the Neupogen, she's going to go back to
Yeah.
0. So when you say try and take her off of Neupogen and do how long off of Neupogen and do a bone
I'd say
marrow?
at least 2 weeks
2 weeks, okay.
Yeah.
And get her in and get the bone marrow done.
and then put it back on.
Okay. That
It's not
fast?
time.
No.
That was 15
No,
minutes?
it's not.
It's not time.
Oh, okay.
I just wanted, I got all the printouts.
So again, that
And,
would be
and should I wait
that's
for the
how-
year to go by that since we
That's
did
how-
the last one, or should
Sure.
I? Yeah, because it takes a lot. It's a lot.
Yeah,
Yeah.
yeah, I
She
wouldn't-
doesn't know, but it's a lot out of me.
Sure.
But she is aging
I
out
think-
of.
and she gets
pediatrics.
sedation for the.
Yeah, they sedated her.
First of all, I'd see if they're going to do that in the adult. You
I know. We
they
just
don't always.
September really. Well, in September we start adult. We have one more visit with her hematologist pediatric. That's the person who diagnosed her with Cohen syndrome, and then we already have an adult.
Yeah. Where do you live?
We live in Florida.
In Florida.
Yeah. So that's a big transition.
Yeah.
Yeah.
So I would find out if they are willing to do sedation because
Okay.
in adult hematology they generally don't, or depending on the center, many of them don't do sedation,
Okay.
and I always wonder why. And I think it's because when an adult hematologist does a bone marrow, it's usually for leukemia or suspicion of leukemia or MDS.
Right.
It's not a routine and it's done
Right.
infrequently and it's
Right.
an emergency.
Right.
And the patient has no choice.
Okay.
Why do you get sedation for a colonoscopy,
Right.
which is less uncomfortable? It's
Right.
because you wouldn't show up otherwise.
Right. Absolutely. I wouldn't.
Right. So I think, it's not because it's not indicated, it's because it's more of a bother.
Well, I'm hoping because she's
And
special needs
I
that
would
they would
hope
take
so.
that into account.
I would hope so.
Because if
But
not,
the
I'll
other
take her to
issue-
Shriners or something.
Yeah,
And
and I would.
yeah.
The other issue is that, sedation is not without its risks.
No, I understand that. Yeah.
And so if you can have no bone marrow, no sedation, I think that's
That'd be awesome. Yeah.
ideal. I think you have to consider the risk and the benefit.
Yeah.
Um,
But I worry
would-
about her
if
being
if
on
she
the
were my patient,
Neupogen.
I would just follow the blood counts. And if she loses the response to Neupogen, if her platelets or red cells go down, then I do a bone marrow.
Okay.
I do it on clinical indications rather than monitoring because I don't think she's high risk. She responds to a low dose of Neupogen.
Right.
She almost certainly has a low risk mutation.
Okay. Now, how up until how many mLs? Because I understand mLs. Is it considered low?
It depends on the weight.
Okay. So 100 pounds.
So 100 pounds. So
A
that's
little more than 100 these days.
okay.
But
So
we'll
let's
go with
call
100.
that 50 kilograms. So below 8. So that's below 400 micrograms. So
So that's a long ways
that's
away.
way away.
Yeah.
Now that's,
Okay. That's good.
That's 1.3 mLs.
Yeah. And
Those
she's
are-
never had she's always responded really well.
Yeah.
And they always say that at hematology, and she responds well to the Neupogen.
Which is good.
But they're like, we want to start doing them.
Yeah.
So,
Yeah. So what I would do is just follow counts every month or two,
yeah. Yeah, we do. Every
Yeah.
month, yeah. Okay.
and only do a bone marrow if there's trouble.
Yeah.
But I think if she has one more bone marrow off
The Neupogen.
the Neupogen and that looks good, that's
Yeah.
an even stronger
Yeah.
indication.
And if it doesn't look good, then what's the flip side? Then just keep doing what we're doing.
Yeah.
And monitor.
Right.
Okay. Have you ever seen any kids with Cohen syndrome?
No.
No. Well, now you know if you do.
Right. Yeah. I always think
Look
of it.
for, yeah.
And in fact, fortunately, it's on the panels now, the
Yeah.
next generation
Yeah.
sequencing panels.
Yeah.
So that's good because
That's
not every
great, yeah.
doctor thinks of it.
We kind of had an explosion of cases come. I think because of families like us,
Yeah.
we've really had a lot of kids getting diagnosed. In the past year, we've had so many. Past 2 years, we've had so many.
Yeah. Dr. Boxer's really been.
Yeah, he's been our guy, but we're going to need someone new because Dr. Boxer is going to retire,
Yeah.
and we need, we want him always. He's on our board.
Right.
I'm part of the board. He's on our board. But if you know students in the Ohio area, we're always looking for students who want to start just really, studying our kids
Yeah.
because they're the unknown. I mean, they're the unknown,
Yeah.
and we need the people to study because we don't know. We're just the parents.
Yeah.
We know more than
Oh, yeah.
anyone else,
Than most
but we
doctors.
don't know the medical jargon, and we need people to really get in
Yeah.
there and study. That's how this paper, or my paper, was. This was done. It was by a
Yeah.
student,
Mhm.
so we really need that. So just if you ever hear of anyone looking for, what can I study? I need something
Yeah.
interesting to study. Please keep us in mind
Mhm.
because we really need that. Okay.
Yeah.
Well, thank you for that
Okay.
bit of information.
You're
Okay, we're
welcome.
saying
Okay.
goodbye.
That helps. Goodbye.
Bye.